Hello everyone, I am Dr. Aisha, working as an Associate Professor in Physiotherapy Department of UN Mehta Institute of Cardiology and Research Center. Today's session we are going to learn about the exercise program for the cardiac rehabilitation and do's and don'ts after the cardiac surgery. Contents for the today's session are the definition, what are the adverse effects of the sedentary lifestyle, cardiac rehabilitation for the cardiac disease, guidelines for the inpatient rehabilitation program, indication and contraindications of cardiac diseases. Before starting the cardiac rehab, we have to go for the screening and assessment. So we will see that. Along with that, risk factor stratification for the patients with the cardiovascular diseases, and then comes the main parameter, that is outpatient cardiac rehabilitation or exercise program. And these are the contents of that. Do's and don'ts of the cardiac surgery or the open heart surgery we will see at the end. Definition of the cardiac rehabilitation. So, American Association of the Cardiovascular and Pulmonary Rehabilitation defines the cardiac rehab as the provision of comprehensive long-term services involving the medical evaluation, prescriptive exercise and the cardiac risk factor modification, education, counseling and the behavioral intervention. So here we can see that the cardiac rehab does not involve just the exercise therapy or the medical therapy, it also involves the risk factor modification. So primary risk factors and secondary risk factors which are responsible for the cardiac diseases, that also should be modified along with the rehab. Education and counseling of the patient and behavioral intervention. So why behavioral intervention? Because physical activity and the lifestyle modification is important for the secondary prevention. So that is the main concept along with the exercise program in the cardiac rehabilitation. Now as we see here, the basic parameter of exercise program is the FIT VP principle. Frequency stands for the how often patient has to do exercise. Intensity is how hard patient has to do exercise. Time is the duration. Type means what kind of exercises. Total volume means the total amount of exercise, and the progression or the advancement of exercise. So it is known as the FIT VP principles of exercise prescription. Now whenever we go for the exercise prescription, we have to see for the clinical condition of the patient as well as the special consideration for the healthy individual. Now this exercise prescription should address the cardiorespiratory fitness and muscular strength and endurance along with the flexibility, body composition and the neuromuscular and the neuromotor fitness. Now adverse effects of sedentary lifestyle. So long period of sedentary activity associated with the elevated risk of the cardiovascular disease mortality, worsen the cardiometabolic disease biomarkers and depression. So here they are saying that the person who are physically active and still have the longer duration of physical inactivity or sedentary lifestyle also have the adverse effect mentioned as above. So it says that the exercise prescription include the plan to decrease the physical inactivity duration in addition to increase in the physical activity. Now cardiac rehab for the cardiac diseases. So cardiac rehabilitation is commonly used to deliver the exercise and lifestyle intervention, consists of the coordinated multifaceted intervention to design to reduce the risk, foster healthy behavior and compliance to this behavior, reduce disability and promote the active lifestyle for the patients with the cardiovascular diseases. So multifaceted intervention means we will look for the all around points for the rehabilitation. So here include the reduced risk. Reduced risk means the risk factor modification we have to do post-operatively. Healthy behavior and compliance to the behavior, that means whatever physical active lifestyle patient has adapted, that patient has to continue and maintain for the lifelong. Reduce disability and promote the active lifestyle as well. So cardiac rehab is typically delivered in both the inpatient, that is cardiac rehab phase 1, and outpatient setting, and reduces the rate of mortality and morbidity in persons with the various cardiac diseases by stabilizing, slowing or even reversing the progression of atherosclerotic process. So through the cardiac rehab phase 1 and 2, we can even stabilize, reverse or slow the process of the atherosclerosis. Now guidelines for inpatient cardiac rehabilitation program, it should be focusing on the following points. First is the current clinical status of the patient. So we have to go through the assessment format and the screening format to see the clinical status of the patient. Second one is mobilization. So as soon as the patient is stable all the parameters are within the normal limits and we can't see any of the risk factors or any adverse effects in the patient, then we can start mobilizing the patient. Next one is the identification and provision of information regarding the modifiable risk factor and the self-care. So patient and relative should be informed about the modifiable risk factors and how we can alter along with the physical activity. And discharge planning with the home physical activity and activities of daily living plan, and referral to the outpatient cardiac rehabilitation. So whenever we go for the inpatient rehabilitation plan, we have to keep this guideline in mind for the patient welfare. Now before starting the ambulation in the inpatient rehabilitation, this should be followed and this should be taken care of. First one is no new or recurrent chest pain within the previous 8 hours. Stable or falling creatinine kinase and troponin value should be present. No indication of the decompensated heart failure, that is resting dyspnea or bibasilar rails, and cardiac rhythm and stable electrogram for the previous 8 hours. Next is the adverse responses to inpatient excise leading to the discontinuation. If the systolic BP increases more than 110 mm of Hg, decrease in the diastolic blood pressure more than 10 mm of Hg during the exercise with the increasing workload, significant ventricular atrial arrhythmia with or without the associated sign and symptoms, second or third degree heart block, and sign and symptoms of exercise intolerance including angina, dyspnea and ECG changes suggestive of the ischemia. Any of these adverse responses are present, we have to stop the exercise immediately. Now moving towards the indications of the cardiac rehabilitation. So mention over here, first one is medically stable post-MI patient are indicated for the rehabilitation, same as the stable angina, coronary artery bypass graft surgery. Post of that patient is indicated for rehabilitation. Percutaneous transluminal coronary angioplasty, stable heart failure caused by the systolic or diastolic dysfunction, heart transplant, valvular heart diseases or valvular heart surgeries, peripheral arterial diseases, at a risk of coronary artery disease with diagnosis of diabetes or dyslipidemia. Other patients who may benefit from the structured exercise and an outpatient education based on the physician referral consists of the rehabilitation team, hypertension and obesity. So here we can see that all the medically stable patient, whether stabilized with the medication or after surgery, are indicated for the cardiac rehabilitation. Along with that, patients with the primary risk factors such as the diabetes and dyslipidemia are also indicated for the cardiac rehabilitation. Contraindications. Now why we have to look for the contraindications? Because among the indication, as we have seen now, some patients are contraindicated and they may have the adverse effect of the cardiac rehabilitation or not allowed to do the prescribed exercise. So that we have to keep in mind first before starting the cardiac rehabilitation. First one is unstable angina. Second, when the systolic BP increases more than 180 mm of Hg and the resting diastolic BP more than 110 mm of Hg are contraindicated for the exercise. So first they have to go for the patient has to go for the medication therapy, decrease in the diastolic and systolic blood pressure, then they can come for the rehabilitation. Second one is orthostatic blood pressure drop more than 20 mm of Hg, significant aortic stenosis. Uncompensated heart failure patient are also contraindicated. Third degree atrioventricular block without the pacemaker, active pericarditis and myocarditis, recent embolism, acute thrombophlebitis, aortic dissection, acute systemic illness or fever are also contraindicated. Uncontrolled diabetes mellitus, severe orthopedic condition that would prohibit the exercise, and other metabolic conditions such as the acute thyroiditis, hypokalemia, hyperkalemia, hypovolemia are contraindicated, and severe psychological disorders. So before going for the rehabilitation, we have to screen and assess the patient for the following points. First, we will take in detail the current medical history, including the medical and surgical profile, including complication, comorbidities and the pertinent medical history. Physical examination, including cardiopulmonary and the musculoskeletal system. ECG, we have to see current medication, including the dosage and frequency, and then we have to see the CVD risk profile, including the following points, that includes age, gender and the menopausal history, use of the tobacco product, level and control of hypertension, level control of the dyslipidemia, body composition assessment, we have to go through it, whether the patient is obese, having the high BMI, low BMI and percentage of the body fat, fasting blood glucose and the hemoglobin level we have to see. Along with that, the most important is physical activity status, including the exercise capacity, how much the patient is spending in the leisure time and physical activity level, daily sitting and sedentary time, we have to note it down. Psychosocial history includes the evidence of depression, level of anger, hostility and the family history. Along with that also we have to take in detail about the anger and the hostility and identify by the questionnaire data. So American Association of the Cardiovascular and Pulmonary Rehabilitation has given the risk stratification criteria for the patients with the cardiovascular diseases. So overall, all the patients are divided into 3 categories, that is low risk, moderate risk and the high risk categories. So while giving the cardiac rehab, we have to see the patient falling under which category, and the monitoring will be based on the risk stratification. So low risk category patients include the absence of the complex ventricular dysrhythmia during the excess testing and recovery, absence of angina and other symptoms, example as unusual shortness of breath, lightheadedness, dizziness during the excess testing and recovery. Third one is the presence of the normal hemodynamic during testing and recovery, and last one is the functional capacity more than 7 meds. When patient is unable to undergo the excise testing or have not undergone the excise testing, we have to see the following criteria. Resting ejection fraction more than 50% should be present, uncomplicated myocardial infarction or revascularization procedure, absence of the ventricular dysrhythmia at rest, absence of congestive heart failure, absence of signs and symptoms of the post-event and procedure of the myocardial ischemia, and absence of clinical depression. If a patient is following or having this characteristic, patient will fall under the low risk category. Now moderate risk category says that the presence of angina or other significant symptoms such as unusual shortness of breath, lightheadedness, dizziness occurring at the high level of exertion more than 7 metabolic equivalents, mild to moderate level of silent ischemia during the excess testing or recovery, that is ST segment depression but less than 2 mm from the baseline, and functional capacity, if it is less than 5 meds, the patient falls under the moderate risk category. Non-excise testing finding suggests that if the ejection fraction is between 40% to 49%, patient is under the moderate risk. Now high risk category says that the presence of the ventricular dysrhythmia during the excise testing or recovery, presence of angina and other significant symptoms on the level of less than 5 meds level and during the recovery time, high level of silent ischemia, that is ST segment depression more than or equal to 2 mm from the baseline during testing or recovery, and presence of abnormal hemodynamic with the excess testing or recovery, then patient falls under the high risk category. Now here abnormal hemodynamic means the chronotropic incompetence or flat or decrease in the systolic blood pressure with increasing the workload. So even though we are increasing the workload, if the systolic blood pressure falls or the heart rate is not increasing, then the patient falls under the high risk category. So now we have seen the 3 categories: low risk, moderate risk and the high risk categories. Depending on this, the monitoring should be done. High risk category further says that the non-excising testing findings. So patient has not undergone the excise testing, but still we have to categorize the patient. So first point is that the resting ejection fraction, if it is less than 40%, patient falls under the high risk categories. History of the cardiac arrest, complex dysrhythmia at rest, complicated myocardial infarction or revascularization procedure, presence of the congestive heart failure, presence of signs and symptoms of post-event or post-procedure myocardial ischemia, and presence of clinical depression. So if the ejection fraction is less than 40%, and history of cardiac arrest and dysrhythmia is present, patient falls under the high risk category. As well as we can see here that the patient having the congestive heart failure also falls into the high risk category. As we have seen the risk stratification, based upon that there is recommendation of intensity of supervision and monitoring related to the risk of excise prescription. Now patient having the low risk, should be monitored for minimum 6 to 18 weeks for 30 days post-event or post-procedure, with the beginning with the continuing ECG monitoring and decreasing the ECG monitoring as appropriate. Patient with the moderate risk should be observed and direct supervision exercise should be performed for 12 to 24 weeks or 60 days post-event. Here also same, beginning with the continuous ECG monitoring and decreasing to intermittent or no ECG as appropriate. And patients at the high risk level should be minimum 18 to 30 weeks should undergo the supervised exercise program or minimum 90 days post event along with the ECG monitoring and decreasing to intermittent with no ECG as appropriate. Now outpatient cardiac rehabilitation are also said as the secondary prevention. Class 1 recommendation is present for in the clinical guideline for the patients with the acute MI, acute coronary syndrome event or angina, coronary artery bypass surgery, percutaneous coronary angiography, angioplasty, heart failure, hospitalization, heart valve repair or replacement, heart or heart-lung transplant. Now goes for the outpatient rehabilitation. So whenever patient comes for the rehabilitation program, we have to keep in mind before starting the exercise program. First one is develop and assess the patient to implement safe and effective formal exercise and lifestyle physical activity program. Second, the provide appropriate supervision and monitoring to detect a change in the clinical status. Third one is return the patient to vocational and recreational activity or modify this activity based on the patient clinical status, and provide the patient and relatives education to optimize the secondary prevention, that is risk factor modification through the aggressive lifestyle management and judicious use of cardioprotective medication. So here we can see that we have to first develop the exercise program and physical activity program for the patient, assist in the implementation. We have to supervise and monitor while giving the rehabilitation, and then we have to see that how much the patient is able to return to vocational and recreational activity through the rehabilitation. Along with that, education is most important parameter in the rehabilitation. So we have to educate the family members regarding the secondary risk factor modification and prevention of the further complication. Now we'll look for the components of the outpatient cardiac rehabilitation. So our components include risk factor assessment and counseling, education and support to the family member regarding the healthy lifestyle change and to reduce the risk of the secondary cardiac event, develop and implement the supervised, safe and effective personalized exercise plan, monitoring with the goal of improving the blood pressure, lipid and cholesterol, diabetes mellitus, psychological stress, assessment and counseling, communication with the physician and other healthcare providers regarding the progress and relevant medical management issue, and return to appropriate vocational and recreational activities. Now before starting the rehab, we'll go for the assessment. So assessment should include the following points: medical and surgical history, physical examination of the cardiopulmonary and musculoskeletal system, review of the risks in cardiovascular test and procedure. So here we have to see all the investigation patient has undergone, current medication including the dose, route of administration and frequency, and CVD risk factors. Why we have to see the CVD risk factors? Because we can modify it along with the exercise program. Along with the risk factor, we also have to take the blood pressure, body weight. Symptoms are evident of the change in the clinical status, not necessarily related to the activity, that is dyspnea at rest, lightheadedness, dizziness also we have to note it down. Symptoms and evidence of exercise intolerance, change in the medications and adherence to the prescribed medication regimen, ECG and the HR surveillance. So we have to see the medication, how much patient is adhered to take the medication, and ECG and HR responses we have to see. American College of Cardiology and American Heart Association 2002 guideline update for exercise testing states that the exercise testing early 2 to 3 weeks or later on 3 to 6 weeks after hospital discharge is useful for development of exercise prescription in patients who suffer from MI without or with the coronary revascularization. So exercise testing is useful not only just to not only just to have a patient's clinical status, but also important to develop the guideline for the exercise prescription. So early exercise testing include the 2 to 3 weeks after the surgery or 3 to 6 weeks after the hospital discharge. Now here comes the main component of the exercise prescription. So frequency, intensity, time and type. So whenever we prescribe the aerobic exercise, strengthening exercise or flexibility exercise, we have to include and prescribe according to this 4 parameter. Frequency means how many times a week patient will do exercise. Intensity means how hard the patient will do exercise. Time is the duration for which patient has to do exercise, and type means which type of exercise patient will perform. Now components of the exercise training session includes the warm-up, conditioning, cool-down and stretching. Warm-up should be at least of 5 to 10 minutes of light to moderate intensity of the cardiorespiratory or muscular endurance activity. So after 5 to 10 minutes, we have to go for the conditioning phase that includes 20 to 60 minutes of aerobic, resistance, neuromotor and sports activity. But for the cardiac disease patient, we go for the aerobic resistance exercise along with the flexibility exercise. Later on, after the conditioning phase, we can include the sports activity. After the conditioning or exercise program, we have to prescribe for the cool down period of at least 5 to 10 minutes, including light to moderate intensity of the cardiorespiratory as well as the muscular endurance activity. Stretching exercises include 10 minutes of stretching exercises performed after the warm-up or the cool-down phase. So these 4 points we have to remember: warm-up, conditioning, cool-down and the stretching. Now aerobic exercise program should be prescribed as follow. Frequency should be minimum 3 days a week or maximum 5 days a week. So patients should be advised to come to the outpatient rehabilitation program for 3 days a week or maximum 5 days a week. Intensity should be prescribed based on the following criteria: 40% to 80% of the exercise capacity using heart rate reserve, VO2 reserve and heart rate peak. When patient has undergone the exercise testing, we can prescribe based on the heart rate reserve, VO2 reserve and VO2 peak. Without an exercise test means patient has not undergone the exercise test, still we have to prescribe the intensity. So we can use sitting or standing HRS plus 20 to 30 beats per minute or RPE of 12 to 16 on the scale of 6 to 20. Considering this intensity, we have to give the exercise for 20 to 60 minutes. So minimum we can start with the 20 minutes. Gradually we can increase the duration from 20 to 30, 40 and 60 minutes. And type of exercises, person can undergo or use the arm ergometry, upper and lower dual action ergometry, upright and recumbent cycles, recumbent stepper, rower, elliptical, stair climber and the treadmill. So here we can see that overall it will give the parameters for the exercise performance. So when patient is coming to you, we have to assess and screen the patient and then we can start with the exercise program. Before starting, during the exercise and after the exercise, we have to take vitals and the RPE to make sure that the patient is not having any of the adverse effect or the chronotropical incompetence. So frequency, if we are starting with the 3 days per week, we can prescribe the exercise intensity based on the VO2R or HRR. We'll see later on how the HRR and VO2R is derived. 20 to 60 minutes of any type of exercise such as the cycling, stair climber, treadmill exercise or recumbent stepper we can use. So here within the 60 minutes we have to include the warm-up exercise, conditioning phase and the cool down phase along with the stretching. Intensity can be based on the heart rate. So heart rate max can be decided based on the following formula. Generally we use 220 minus age and it is indicated for both men and women. Apart from that also we can use the other formulas like this. So decide the HR max. From the HR max we can derive for the heart rate reserve. So these are the various formula from which we can derive the exercise intensity. First one is the heart rate reserve. So for the heart rate reserve, we have to take HR max minus HR rest into the percentage of intensity desired plus HR rest. For VO2R, we have to take VO2 max minus VO2 rest into intensity desired plus HR rest. HR method also includes the target heart rate that is HR max into percentage of the intensity desired. So directly we take the percentage of the HR max. In VO2 method also we have to take the percentage of the VO2 max and we can go for that much intensity level. And metabolic equivalent method. So metabolic equivalent is equal to VO2 max divided by the 3.5 ml per kg per minute into percentage of intensity desired. So we have to divide the VO2 max by the 1 MET value, that is 3.5 ml, and percentage of that we can use as a intensity to prescribe the exercise. Now here in this table we can see the different intensity that defined as the light, moderate and the vigorous exercises. First is the percentage of HRR, second one is percentage of HR max, percentage of VO2 max, RPE, the most important when we are prescribing the exercise without the testing. So here we can say that the RPE value gradually increases from the intensity very light to vigorous. RPE less than 9 is considered the very light activity. From the 9 to 11 is the moderate light activities. Moderate activity include the scale of the 12 to 13 and vigorous intensity is between 14 to 70. Not only this, but we can prescribe depending on the MET value also. So MET value here is given for the age group, as we can say that the absolute intensity or the MET by the age. So for the younger age group, the very light activity is 2. It increasing the MET levels such as 2.9, 5.9 and 8.7 from the light to vigorous activity. Same way if we go for the MET values for 40 to 64 years of age, it is less than 2.0, from 3.9, 5.9 and 8.4 for the light to vigorous activity, and more than 65 years of age, the MET values are lesser than the previous mentioned values, that is less than 1.6 up to 3.1, 4.7 and 6.7. So here we can say that as the age increasing, the MET values are decreasing for the intensity of exercise. Now one table is given for the metabolic equivalent values depending on the various activities such as the walking, running, stepping, leg cycling and the arm ergometry. Generally for the patients we go for the walking, cycling and the arm cycling. So MET values we can calculate by the given formulas over here. Now calculation of the MET per minute and the calorie per minute. So metabolic equivalent. So what is metabolic equivalent? It is the index of the energy expenditure. A MET is the ratio of the rate of the energy expended during an activity to rate of the energy expended at rest. So MET is the rate of energy expenditure while sitting at rest, and by convention that is 1 MET is equal to an oxygen uptake of 3.5 ml per kg per minute. Now MET minute, it quantifies the total amount of the physical activity performed in the standardized manner across the individual and type of activity, calculated as the product of the number of MET associated with one or more physical activities and the number of minutes the physical activities are performed, that is MET minutes. So we have to first calculate the metabolic equivalent for the activity and then multiply it by the minute the person has performed the activity, then we'll get the MET minutes. And usually it is standardized per week or per day as a measure of exercise volume. So whatever MET minutes we are getting, suppose we are getting 30 minutes of the MET value and that is performed 3 days per week, so that we have to calculate according to this formula. So in the second line we can see that 7 MET activities performed for the 30 minutes and for 3 times per day. So we'll get the 630 METs minute per week. So METs minute per week we have to calculate for the weekly. Kilocalorie, it says that the energy needed to increase the temperature of the 1 kg of water by the 1 degree Celsius, and to convert the metabolic equivalent into kilocalorie, this formula is used, that is metabolic equivalent into body weight divided by 1000 into 5. So in the below formulas and calculation we can see that the 7 MET is multiplied by the 3.5 and this for the 70 kg of person, for example, because here they have taken the example that the jogging at the level of the 7 METs for the 30 minutes for 3 days per week, and the person who is performing the jogging is of the weight of the 70 kg. So 7 MET into 3.5 into 70 kg we have to divide by 1000 into 5, so we'll get the 8.575 kilocalorie, but that the person is doing for 30 minutes and 3 times per week, so we'll get the 771 kilocalorie per week energy expenditure. Now after the exercise program for the aerobic exercise, we have to see the exercise protocol for the resistance exercise as well as the flexibility exercise. So resistance exercise we cannot go for more than 3 days per week, or so therefore 2 to 3 days per week, and that is also consecutive days per week, and it is performed as RPE of 11 to 13 on the scale of 16 to 20 number scale, or 40% to 60% of the 1 RM. So whenever we ask the patient to go for the resistance exercise, we have to ask them to perform 10 to 15 repetition for each exercise without any fatigue. So that intensity or hardness level should be 11 to 13 on the RPE scale. After 10 to 15 repetition, we ask the patient to go for the other group of exercise so that we can relax the same group of muscle. And the time is 1 to 3 set patient has to perform for 8 to 10 different exercises, focusing on the major muscle group. Type of activity, anything you can decide depending on the condition of the patient, but it should be safe and comfortable for the patient. So whenever you go for the exercise protocol, along with that you can take the upper limb muscle group strengthening one day, and next day you can go for the lower limb muscle group strengthening. Now in the upper limb and lower limb muscle strengthening also, you have to go for the opposite muscle group strengthening. Suppose you are giving for the elbow flexor for the 10 to 15 repetition, next you give for the elbow extensor, then the shoulder muscle group, and then the scapular muscle group. So same way you have to switch the muscle group so that it won't be stretched for more than one cycle or one set, and this one set is repeated for the second and third time, so that the patient have the different muscle group strengthening without the fatigue. So resistance training, again I'll repeat it here, 3 days consecutive days per week we have to take. Intensity should not be 40 to 60% of 1 RM. So we have to check first what is 1 RM, and 40% or 30% of that we have to start with, and we have to take major muscle group and prescribe exercise such that patient won't feel fatigue. Flexibility exercise also 2 to 3 days per week it is prescribed, to the point that the patient feel tightness or slight discomfort. So we can prescribe here the static stretching, dynamic stretching, as well as the PNF stretching. Do not go for the ballistic stretching over here. And stretching also maintain for frequency for the time duration of 15 seconds, along with more than 4 repetition for each exercise. So 15 to 20 seconds of stretching we have to prescribe for 2 to 3 sets. So flexibility exercise also 2 to 3 days per week, to the point where the patient feel tightness, and 15-second hold with the 3 to 4 repetition. And here we have to go for the dynamic and the static stretching. Now after going through all the exercise program, we have to consider some points for the patient, that the frequency of exercise depend on the several factors, including the baseline exercise tolerance, intensity, fitness and health goals, and type of exercise that are incorporated into overall program. So we cannot prescribe the same intensity and same protocol and same duration for every patient. It depends on the patient to patient, because all the patient does not have the same exercise tolerance and same fitness level, and does not want to have the same goals for them. So we have to prescribe individualized. And the adults and the older adults suggestive of exercise boosts of at least 10 minutes. So after 10 minutes we have to give break, or we can go for the circuit training or circuit interval training for the patient, so they won't feel the fatigue, and after 5 to 10 minutes they will have the break. Patients with the very limited exercise capacity should have the multiple shorter session daily, and this should be considered as a starting point. So patient with the limited exercise capacity means they have the less capacity, cannot able to walk for the longer duration, or cannot able to perform for the longer duration. For them we can start with the less than 10 minutes, but for the multiple sessions. So this can be the starting point, and gradually we can increase the duration more than 10 minutes according to the patient's tolerance. If beginning with the less than 10 minutes goes, gradually increase the aerobic exercise time is suggested, and this may be as little as 1 to 5 minutes per session, or 10 to 20% of week. So as I said that the aerobic Exercise duration should be increased, but it should not be increased directly from the 5 minutes to 10 minutes. Gradually we can add 1 minute per session and increase the duration from 5 to 10 minutes, or as 50 to 20% of the total weekly session. If a patient has identifiable ischemic threshold, that is angina or ST segment depression more than 1 mm on exercise test, the intensity should be prescribed at an HR or work rate below this point. So if such a threshold has been determined, the upper limit of HR based intensity should be a minimum 10 beats per minute below the HR level at which the ischemia was identified. That means if the threshold is determined at which the heart rate also determined, the heart rate should be always below that level, and if the peak HR is unknown, the RPE method should be used. Now RPE method is used as a following: less than 12 is slight, less than 40% of the HRR, 12 to 13 RPE on the 6 to 20 point scale, or 4 to 6 on the CR10 scale indicates the somewhat hard, or else the 40 to 59% of HRR, and 14 to 16 on 20 point scale or 7 to 8 on the 10 point scale is indicated at hard, or 60% or 80% of the HRR. So this HRR method less than 40%, 40 to 59% and 60 to 80% can be considered for the patient having the peak HR unknown. And it is also preferable for individual to take their prescribed medication at the usual time as recommended by the healthcare provider. Individuals on the beta adrenergic blocking agent may have the attenuated HR responses to exercise and an increase or decrease in the maximal exercise capacity. So patient is having or on the medication of the beta adrenergic blocker, they should undergo the new graded exercise test after they have started with the beta blocker. So that will come to know the exercise capacity based on the RPE. And also the patient on the diuretic therapy are at the elevated risk for the volume depletion, hypokalemia and the hypotension, particularly after the boosts of exercise. For this patient, the BP responses to the exercise, symptoms of dizziness and or lightheadedness and arrhythmia should be monitored while providing the education regarding the proper hydration, as well as whenever we perform the exercise with the patient on the diuretic therapy, we have to take the BP measurement during, before and after the treatment and inform the patient if the patient is feeling any of the dizziness or lightheadedness, they have to immediately inform the therapist. During each exercise session, warm up and cool down activities of 5 to 10 minutes. It should include the dynamic and the static stretching. Light or the very light aerobic activity should be performed. So it is must for the any therapist that they have to start with the warm up and end with the cool down. So any adverse effect of exercise we can decrease by the warm up and the cool down phase. The aerobic exercise portion of the session should include the rhythmic large muscle group activity with the emphasis on the increased caloric expenditure for maintenance of healthy body weight and its many other associated health benefit. So type of exercise, it is saying that it should include the large muscle group and rhythmic activity. It should not include any jerky action while prescribing the exercises. Along with that, we also have to calculate the energy expenditure for the total weekly, as we have seen in the previous formulas. Safety factor that should be considered include the patient clinical status, risk stratification category, exercise capacity, ischemia or angina threshold, musculoskeletal limitation, cognitive and psychological impairment. Resistance training in volume can be increased 2% to 10% increment when individual patient is able to comfortably complete the 1 or 2 repetitions over the desired number of repetitions on 2 consecutive days, and avoid breath holding during the resistance training and the static stretching. So here we have to keep in mind the risk factor stratification, how much the exercise capacity patient has. If the angina threshold or ischemic threshold is known, we have to give the exercise below this level, which are the musculoskeletal limitations such as the patient is having OA, back pain or any other limitation because of patient is not able to perform any one type of exercise, so we can go for the other type of exercises. And while giving the resistance training, we have to keep in mind that the increment should be gradual from the 2% to 10%. So we can increase 2 or 3% of the intensity of exercise. We can increase in the resistance training. And while performing the resistance training, make sure that patient or the client should not hold the breath while performing the strengthening exercises. Now, exercise prescription without and participation exercise test. So, pre-participation exercise test, if it is unable or unavailable, the RPE should be used as a intensity parameter to guide the protocol, and patient should be closely monitored for the sign and symptoms of the exercise tolerance such as the fatigue, dizziness, lightheadedness, chronotropic incompetence, and the signs and symptoms of ischemia. So RPE should be used along with the sign and symptoms should be closely monitored to see any of the adverse effects. So for the lifestyle physical activity level, we have to make sure that the patient continues with the exercise session as well as continues with the weight reduction and weight maintenance program, along with the most important one, the severity risk factor reduction. So if person is attending the outpatient rehabilitation program, per session they may spend 300 kilocalorie. So those attended 3 times per week expend less than 1000 kilocalories per week, and this is important for the risk factor reduction as well as the weight maintenance. And it is also important to encourage the patient to perform regular physical activity and purposeful exercise outside the program participation. So in addition to the outpatient exercise program, patient has to do regular physical activity and maintain it for the longer duration. In addition to formal exercise session, patient should be encouraged to gradually return to activities of daily living such as the whole course, yard work, shopping, hobbies as evaluated and appropriately modified by the rehabilitation staff. So these all activity patient can perform gradually and that also with the care, but after the 3 months of the surgery. Relatively inexpensive pedometer, smartphones with this stepping technology and other wearable devices can be useful to monitor physical activity and enhance the adherence to the walking program. As we know that all the phones might have the application which count the steps or the pedometer. Patient can use or wearable devices like the smartwatch nowadays having the calculated stepper. So patient can use these devices to guide how much steps they are taking daily or weekly to guide the walking program. Now we'll see the do's and don'ts for the patients after the cardiac surgery. So we can say the patient that you can stay active during recovery but start slowly, do not pace fast or do not go fast. So always ask the patient to wear the chest binder while traveling or walking for at least 3 months. Walking is a good exercise for the lungs and for the heart after surgery, but do not concern about how fast you are walking, but take it slow. So always ask the patient to go for the slow walking. Do not increase the speed of walking, but they may increase the duration gradually. Stair climbing is okay for the patient, but be careful, balance may be a problem, and rest halfway up the stairs if you need to. So advise the patient to stop while stair climbing. Do not climb the 3 or 2 flights of stairs at a straight go. Light household chores such as these setting a table, folding clothes, walking and climbing stairs should be okay for the patient. Slowly increase the amount and the intensity of your activity over the 3 months. So here it says that slowly patient has to go. Do not increase the amount of exercise or amount of work suddenly. Do not exercise outside when it is too cold or too hot, and stop if you feel the shortness of breath, dizziness, any pain in your chest. Do not do any activity or exercise that causing the pulling or pain across the chest, such as using the rowing machine or the weightlifting. Also avoid working out right before or after the eating. Maintain minimum of an hour of gap between eating and workout. While walking up, traveling, coughing, support your chest, and therefore it is advisable to wear the binder for at least the 3 months while walking and traveling. Turn to the one side and keep your hands over the chest as you climb out of the bed. So while getting in or out of the bed, do not support the hand on the couch or on the bed. Rather than ask the patient to support on the chest wall, crossing the chest with the hands, and then they lie down and get up. Whenever there is swelling present in the leg, ask the patient to wear the pressure bandages and take the medication on the regular time, consume the nutritious food and avoid the taking oily and the fatty foods. Now regarding the wound care, always ask the patient to support the chest with the hands crossover or with the pillow while coughing. For first 6 weeks after surgery, you must be careful about the using your arm and the upper body when you move. So advise the patient, do not stress the hands and support the chest while moving. Do not reach backward or over the head. Do not let anyone pull your arm for any reason. For example, if they are helping to move around or to get out of the bed. So to get out of the bed or chair, do not let anyone pull the patient's arm. Do not lift anything heavier than 5 to 7 pounds or 2 to 3 kilograms. Do not do even light household work for at least 2 to 3 weeks, and check with your provider before using the arm and the shoulders more. So always advise the patient to use the arm till the shoulder level. Do not reach above the head or do not bend backward, and avoid lifting any of the heavy weight for at least 2 months. Now when you advise the patient for the lifestyle activity and home exercise program, or always ask the patient to stop if patients feel any of this following criteria: pain in the chest, neck, face and the back, severe perspiration, nausea, vomiting, dizziness, ask the patient to stop exercise, unable to comprehend the surrounding environment or reduce the alertness. If any of the above occurs, stop the exercise and remain calm and deep breath for 15 to 20 minutes. Or if the symptom persists, contact the nearby emergency services. Advise the patient for the same. And if the blood is oozing from the nose, ear, mouth, contact the nearest medical center right away. So here we will conclude this session. I'll revise it and summarize it for you. We have to see the patient for the screening and assessment, indication, contraindication, risk factor stratification. After all this, taking the detailed assessment, we can start with the aerobic exercise program, resistance and the flexibility program using the FIT principle. Aerobic exercise, we have to go for 3 to 5 days per week using the light intensity, gradually increase to moderate intensity. For intensity prescription, we can use the HRR and VO2R method. Duration of exercise should be 20 to 60 minutes, and all the larger and major muscle groups will include while giving the different modes of exercise. Same for the resistance and the flexibility training, we have to give for 2 to 3 days, including the light intensity exercise with the resistance, and go for the 20 to 30 minutes including the major muscle group without the fatigue. And along with all this, we have to consider the special need of the patient while prescribing the exercise program. Now here with the end this session. Thank you.